My name is Lewin. I'm a perinatal specialist and educator consultant at White Ribbon Alliance. And I am here today with my colleague Julie Body and also the wonderful Dr. Tonye Wokoma. And we're going to be discussing perimenopause, answering a few questions. If you do have questions throughout that pop into your head, please feel free to pop them in the Q&A. We will look at them intermittently, and you have on the top of your screen the option to raise your hand if there's anything that's really pressing or if you would like to engage with us further. Thank you for those that are already introducing yourselves in the chat. I'm just going to hand over to Tonye to introduce herself and tell you all a bit more about her skill set and the work that she's doing in this area.
Hi, hello everyone. Thank you, Leah. Thank you, Julie. I'm Tonye Wokoma. I'm a menopause specialist and a consultant in sexual and reproductive health. I work up north in Hull, and I'm a trustee of the charity White Ribbon Alliance as well. So thank you very much, and I'm looking forward to a wonderful, really interactive evening.
Yes. So, I'm really looking forward to this conversation tonight because I am in a place where it's something that I'm approaching. I work in the area of sexual and reproductive health, but my knowledge on perimenopause and symptoms and outcomes and things is fairly limited. So I will be learning and discovering with all of you here today. We also have Julie Body here, who is our movement director, who is here helping out with the Q&A and will be getting involved throughout the session as well. So I guess we'll jump straight into it. And the first big question is, what is perimenopause and how long does it last? What do we expect when we start to experience this wondrous perimenopause that everyone's now talking about?
Yeah, no, thanks, Leah. It's a good starting question. What is it exactly that we're speaking about? So if I just go back a little bit, all baby girls are born with the amount of eggs in their ovaries that they will have for life. That's different to boys because boys keep on regenerating and producing sperm. But girls were born with the number that we will have for life. And we get to puberty and our brains, something in our brain wakes up and we send hormone messages to the ovaries, and the ovaries start to release hormones in a cyclical fashion. And if everything's normal, usually girls after a year or two will have a regular cycle where they have regular periods, and that will carry on unless they take contraception or they fall pregnant, and it carries on until they get to the perimenopause, which is usually over the age of 40. And what's starting to happen by that time is we've lost quite a number of eggs. The ovaries are beginning to become a little bit more resistant, is the word we use, to these hormones from the brain. And they begin to release hormones in a sort of chaotic fashion. So instead of the nice regular fashion, regular cycles that we used to have, the main hormones being estrogen, progesterone, and testosterone, these hormones will then start to be released, mainly estrogen, in a bit more of a chaotic fashion. And some women will start to experience symptoms at this time. And that's the time we call the perimenopause, the start of the menopause transition. As they go along, eventually, the number of eggs in the ovaries will reduce and reduce, and it will get to a point where usually when they're less than 1,000, where the ovaries will stop producing the hormones, the estrogen, progesterone, in a cyclical fashion, and the levels will fall completely. And people continue to, that's the menopause. And people continue to experience symptoms, but they may change. And we never used to talk about perimenopause before because the symptoms could be intermittent. The symptoms could be strange. We're not sure, perhaps, maybe. But I think there's much more awareness about it now. Yeah. And it can go on, can go on for lots and lots of years before people actually say, I'm not sure, I'm not feeling quite right. There may be something the matter. What can I do about it?
Yeah.
So
What is this I'm experiencing?
yeah.
Um,
So it's the start of the menopause transition, essentially.
yeah. So just a thought from what you said there. I've heard recently the term premature follicles when in when we're talking about perimenopause. What does that mean when they're talking about premature follicles and reduced and premature? What is that?
So I'm not sure, but it might be that you're speaking about premature ovarian insufficiency. So there's different types of
Yes,
menopause.
yes. Sorry, yes.
And premature menopause, or premature ovarian insufficiency, is when a woman goes through the menopause under the age of 40. So in the UK, the average age of the menopause is about 51. Anything between 45 and 55 is normal. But if a woman goes through the menopause under the age of 40, that's a little bit early. And the reason it's important is because it has an impact on her heart health and her bone health. And we know that it increases risk factors for some other things as well. And so when women, if they can have hormone replacement, we strongly encourage them to have hormone replacement because it protects their hearts and it protects their bones.
Yeah. And I do
The
have a question about
yeah,
that one later on as well. Sorry to
yeah.
cut you.
So we've talked about perimenopause, we've talked about premature ovarian insufficiency when they go through the menopause under the age of 40. Between the ages of 40 to 45, it's still early. And if that happens, I usually say, please see someone about it. And then the menopause is when periods stop, essentially. And
Completely.
completely. And it's a retrospective diagnosis. You can only say a woman's gone through the menopause 12 months after she stopped having periods. But all this could happen as a result of treatments, as a result of illness, all sorts of things. So there's surgical menopause and medical menopause as well, because for various reasons.
Yeah. Thank you. Okay, so how will obviously we've talked about it a little bit, but how does it actually affect your menstrual cycle? What should we expect when we find ourselves wondering if we're at the right age or if we're having certain treatments, like you said? What should we expect when we're coming into that phase of our life?
For a natural menopause, women can start to have irregular cycles, so their cycles can get shorter. So they may have periods a bit more frequently. They may notice that the periods are getting heavier, or
Heavier.
it can get heavier. They may notice that the periods are becoming the bleeding is a bit more prolonged as well. So things can change.
Yeah.
Now, if a woman is over the age of 45 and things change dramatically, I usually say, please go and see somebody about it and just make sure there's nothing else going on.
Yeah.
But it is normal as people go through the menopause, perhaps the cycles get shorter and then they start to lengthen out. So they may miss a period, miss 2 periods, and then have, normal periods for 3 months. And then they may not get another period for 6 months. All that's completely normal.
Yeah.
But if it's really heavy and you're becoming anemic and you're not feeling very well, it's all those sorts of things, then yes, please see somebody.
So we talk about the menstrual cycle and those sort of symptoms, the ones that we expect, but I mean there's the stereotypical ones as well, like the hot flashes and things like that. What are the most common and maybe even some unusual symptoms that we can expect when we're coming into perimenopause?
The most common symptoms that people report is, like you've said, the hot flushes and the sweats. But menopause symptoms can be anything and everything. And that's one
Okay.
of the issues because a lot of the symptoms can overlap with other conditions as well.
Yeah.
I sort of group them into 5 groups. So the sweats and flushes we call them vasomotor symptoms. And there's a reason they happen because the thermoneutral zone in the body begins to we have like a thermostat in our bodies and it gets narrower, the range becomes narrower and narrower. So any swing in temperature causes you to either sweat or feel cold because some people get cold flushes. But it's happening because of a reduction in the estrogen. So that's one group of symptoms. Then the main thing that seems to bother women the most are the psychological symptoms, the cognitive symptoms. the brain fog, the forgetfulness, the going upstairs to find something syndrome and forgetting what you went upstairs to do, opening the fridge, not quite sure what it was for, the inability to multitask, all those sorts of things that we could do previously. And we begin to feel I'm not on top of my game. And this is the thing that I think causes women to lose confidence as well, because they don't feel their brains are working as they used to. Then mood swings, of course.
Yeah.
Then other things that often people think, oh, I didn't realize that was a menopause symptom, are things like joint pain, joint aches, the vaginal dryness. Again, even in 2024, a lot of women don't talk about and perhaps have experienced it for many, many years, or they don't realize, or bladder symptoms that come along with the menopause, the frequent urine infections, the irritability, so the urgency, you need to go, the key in the door syndrome, you need to get to the loo, you need to get to the loo. The other weird and wonderful things like ringing in your ears, a feeling of insects crawling underneath your skin, all over your body, dry eyes, dry mouth, gum
So
problems.
it's not just the vagina, it's all of the mucus glands that tend to.
Yeah,
Okay.
yeah. So there's a whole range of symptoms that women can experience. And most people, studies do show that they can experience up to at least 7 symptoms. And 25% of women who experience menopause symptoms will have severe, debilitating, can't function type of symptoms as well. And some people are going to be able to cope quite well if they have no symptoms, or they don't get many at all, and they're able to cope.
Yeah.
And it can go on for a while. And that's the problem. People say, when is it going to stop? That on average it could be 8 to 12 years, but for some people it's forever, and some people, like I said, don't have many symptoms at all.
Yeah. I think it's the unknown that's daunting. Like we talk about it a lot when we talk about birth and the perinatal period, that actually sometimes when people are experiencing trauma or a lack of control and they're experiencing poor mental health outcomes, it's because of the unknown and the lack of control. So I presume it would continue into the menopause era of our lives, which is
uncertainty and not being in control of your body is something. People don't come and say, I'm not sure what's going on, but you can tell it's worrying, it's scary. Is it going to get worse? Is it going to get better? When should I start medication? Should I start medication? What should, it's all those questions that go around in people's heads. But it's the uncertainty that plays into it. Can I cope? I think I'm going to cope. I want to cope without medication, but no, I don't think so. There isn't any right or wrong answer with any of that at all.
So as a Black woman, I have been in induced menopause as a trial treatment for my endometriosis. And as I alluded to a bit earlier on, I'm now in a phase where I am starting to experience perimenopausal symptoms. I've had some tests done, and some of the symptoms that you've spoken of, I've definitely noticed them. I was told that due to my own hormone imbalance, because of my endometriosis and PCOS and other things, my life expectancy will be reduced by about 10 to 15 years. Is that an appropriate prognosis given the complexity of menopause and sexual and reproductive health as a whole? Because I feel like that's a very broad assumption, but is there evidence behind this?
No, I think that's a very harsh sentence, isn't it, really? And I don't think anybody can actually say that for certain. I think with Black women, perhaps so if we go back to menopause, menopause is not just a biological phenomenon. It's not just to do with hormones. People's experience of the menopause is to do with their biology, it's to do with their hormones, it's to do with their psychology, it's to do with their socio-cultural mindset, environment, what they believe, what they don't believe, etc. Now, we know across the life course, as you've alluded to, Leah, that perhaps women from ethnic minority groups, particularly Black women, seem to have worse outcomes.
Yeah.
For various reasons. You know, if you look at maternal mortality, if you look at cervical screening, if you look at different outcomes. And it's no different with menopause, I think. Not we can't measure their outcomes per se, but if we use, for example, something like hormone replacement as a proxy, which is a very crude proxy for treatment of menopause symptoms, Black women are much less likely to use HRT than white women. So a study that was done earlier this year, the Health Indonesian study, white women will be 5 times more likely to use HRT than Black women. Now,
wow, significant.
So I think it's all these things that perhaps contributes to the health inequality. Whether that reduces people's lifespans by 10 to 15 years, I wouldn't be bold enough to say that. But
I was very shocked.
it does, it will have an impact. And it's about understanding better what people need for their care, how they access care, what kind of care they want, what's the best thing for them. And there's all sorts of things like lack of research, we need more research, exactly, all them sorts of things. But yes, I think there is inequality in menopause care, as well as lots of other things throughout a woman's life course.
That brings two things to mind. The first being, I remember, I think maybe 2 or 3 years ago, speaking to my grandmother about her experience of going through menopause. I mean, she is a mother of 7 and grandmother to 13. I want to say 13, don't quote me. And a whole lot of life experience, but she insisted that she never even noticed when she went through menopause because perimenopause doesn't exist in her mind. That's not a thing. It's something new and made up because she's of that generation that didn't really acknowledge the lead up to it. But she said she didn't even notice it. And there is still so much stigma around conversations about our sexual and reproductive health in the Black community, which leads to loads of misconceptions and what is or what isn't normal when it comes to our health. So when it comes to maternity or perinatal health, I'm really confident in that side, but trying to dispel myths and offer advice to Black women, even myself, that are approaching perimenopause, where's the starting point? Where do we go for culturally appropriate information that is respectful, that is safe, that understands the nuance of being a Black woman and our experiences with healthcare as a whole throughout our life cycle? Where do we go?
No, that's about
Loaded.
5 questions in there.
It is, sorry.
You're absolutely right, Leah. Where's the representation in the media of somebody who looks like me that's going through the menopause, who may experience or have experienced some of the issues that I might have had culturally? And there are many more forums online now for Black women than they were before. Traditionally, a lot of education and awareness and knowledge came through our mothers, through our grandmothers. But culturally, menopause wasn't something where people needed help and support. And so I think
Needed.
it's needed because what people say is, oh, what did our mothers do? What did our grandmothers do? And they didn't need all this medication. They didn't need all this support. But there will be somebody, some of them that would have had a terrible time of it.
Yeah.
But
But
would have
not being
just,
able to talk it down to
they'd have
menopause.
pushed through because it was unacceptable to say it's an issue. Or even if you'd gone to a doctor, the doctor would have said to you, oh, don't worry about it. It's just because that's happening till today.
Yeah.
It's the menopause. It will pass. Or just get on with it. And so that's what people did. That's what women did.
Yeah. Yeah. Very, very common.
And it's not to say that because I think whether to start treatment or not is a personal decision.
Yeah, it must be. Yeah.
So
I know I'm definitely torn.
On the other hand, you force people because people go, oh, why are people HRT hesitant? Da, da, da. You can't force people. Actually, I think the most valuable thing that women want is for someone to listen to them, for someone to understand what it is that they're going through, for somebody to explain to them. For some people, just an explanation that there's nothing wrong with them is enough. And then to explain to them and support them. And if you're distrustful of healthcare to start off with, or you go and you get pushed back, you might not go again because you haven't got that confidence.
Yeah.
So your question, one of your questions is, where do you go for support? You come to things like this, where it's a safe space. You can ask any question. It's not, no question is silly, no question is stupid. Talk to people, talk to other people. I think people are more open now to using or accessing help. But people weren't sure, and there's lots of myths around as well about if you use medication, this will happen and that will happen, and it causes cancer, and it does this and it does that. So again, it's about educating yourself, about doing some research. What is the actual truth? What can I do? And it's not all about medicine. It's about lifestyle. It's about mental well-being. It's about, is there herbal remedies I could use? It's everything really, but it can be a really confusing space, Leah. It's information overwhelm, and it's misinformation as well. It's not just the right information out there, apart from the fact that it's difficult to find somebody who represents what you look like, who you look like.
We actually have a question from Suzanne, and she's asking, regarding the research that you mentioned earlier, where Black women are less likely to use HRT, is it because white women have more access, or are they more likely to speak up? What would you find in your experience?
Why that happens, we can speculate, but in my clinics, I hardly see any Black women. Now, of course, the number, the proportion of Black people in the community is much less, but it's not as small as the numbers I see in my clinic. And I think it's because there's lots of reasons, isn't there? But the perception is you're meant to be stoic, you're meant to be strong, it's not something you need help for. You'd rather pray about it, you'd rather, talk to people, and even then they may not give you the right answer. And then, of course, when you go to speak to healthcare professionals, perhaps Black women don't describe their symptoms the same way other women describe symptoms. So it may not be recognized both by the woman or her doctor or nurse or whoever. And eventually, when it comes to, oh, okay, here's medicine you can take, again, it's that, oh, I'm not sure. Somebody said this might happen and that might happen. So I think there's lots of barriers to people actually accessing help, receiving the treatment, trusting the treatment, taking the treatment consistently, and being supported through it all. So,
and that's, I guess that's representative of the manifestation of diseases and mental health and things. They show up differently in Black people, and that's a generalization, but it's very difficult because when you think about cultural beliefs and philosophical beliefs and things that have been handed down through generations, which could be correct or misinformation, it could be that these areas aren't researched because it's part of a culture that is not really identified in the Western world, and things like that, they all impact how we then receive care, how we perceive care. And it sounds like it's another challenging period, but then conversations like this can prove quite hopeful, because it just goes to show there are people out there doing the work like yourself that are educated, and you have the evidence-based information, and you understand the complexities of the racial disparities that we've experienced from childhood into adulthood when it comes to our sexual and reproductive health. And I think again, as someone who, this is real life for me, it's not just a hypothetical conversation, it's real life for me with the complexities of my own health. It gives me hope, and I feel a lot of gratitude for the work that you do for women that look like us and have these shared experiences.
No, thank you, Leah. I think there's so much work to do. I think we've come away, actually, there's much more information available. There's people are coming forward, they're opening up, they're, acknowledging that it's an issue. But there is still much more to do. And it is about continuing to speak about it, about getting people to recognize that sometimes it's okay to accept help, and to seek and to advocate for themselves almost, and to seek, trustworthy sources of support and help, and not just from healthcare professionals, but from peers, from all sorts of, different areas. And even I say to people, if you can't find somewhere to go to seek help, start one yourself. It might just be an opportunity to do something as well. If you're having problems, you don't know where to turn, who to speak to, what to, where to go.
Mm-hmm.
If you find out some of the information, start a movement, start it yourself.
Yeah,
Start
that's very
looking
true.
for it.
That is very true. I might throw that one back at you in a week. We've got a couple of questions coming in. So I'm going to continue in order. Julie has said women comprise 80% of people with autoimmune disease, and Black and Asian women are the majority of those with autoimmune diseases. Is the lack of HRT use or menopause in general part of why so many Black and Asian women get these diseases?
We don't know, Julie. It's a really good question. Does it get worse in the perimenopause? Does it get better? Again, it's difficult to say. Hormones, do they impact it? Essentially, what I'm saying is we need more research. We need more research into the experiences of Black women, the impact of, and not just Black women, all marginalized women as well, women with learning disabilities, women with ADHD, everybody. How does that impact on how they experience the menopause? Does it make it worse? Are there symptoms? Do they last for longer? Do autoimmune conditions start up in the menopause in these women? It's all those questions that we need answers to. There is more research now. The thing about these things is they happen all very slowly, but it is beginning to happen. So, hopefully our daughters collectively won't have to go through the same lack of information and lack of data.
I hope so. I'm so hopeful for that. We have another question, and please unmute if I get this wrong. Sonu has asked, is that right?
It's Sona. If
Sona.
if you're talking about me, Sona.
Yes. Thank you. Apologies for the error. Sona has asked, do conditions like PCOS, endometriosis, fibroids, etc., that disproportionately impact Black women also impact menopause? For example, if you've always had irregular periods due to PCOS, should you brace yourself for an irregular menopause? And that's really interesting because I've always had, well, not always, but in recent years, very low estrogen. And that was a question I had in the back of my mind, which I didn't think to ask. So thank you for prompting me. That's a very good question. What would you say is the outcomes?
Like we mentioned earlier, so the answer is the simple answer is no.
Okay.
So conditions like PCOS, endometriosis, fibroids will not impact on a woman's menopause experience. They won't make it worse or they won't make it better. More Black people suffer with PCOS, fibroids, etc. Those conditions in themselves have implications for women's health.
Right.
And the thing about menopause, again, it's an opportunity for people to look at their health in total.
Mm-hmm.
Because with something like PCOS, for example, it puts people at a higher risk of developing diabetes. And if that starts to happen, I find in my clinic that the women who sweat and I can't seem to get on top of it with treatments, they probably have a background history of sugars that are not quite stable.
Mm-hmm.
So it can do in that sense.
Yeah.
As opposed to those conditions making menopause worse in itself. And it's to do with symptom overlap, symptom diagnostic overshadowing.
Yeah. So I find that really interesting. And I'm curious because, again, speaking from my own experiences, what was it called? You mentioned it earlier when I said the premature follicles. That's not what it was called.
Yeah, the premature ovarian insufficiency.
So I have that. And I was under the impression that was due to the strain, my endocrine system, and just my gynecological needs over the years and complications.
I completely agree, Leah. I think we quote that 1% of women go through the menopause early, so under the age of 40. Yeah, so 1 in 100. I think it's far higher. I think there's much more, especially in Black and ethnic minority groups. I think because a lot of those women have children perhaps a little bit earlier, once they've completed their families, they don't often notice if their periods start or stop or when it is happening exactly, as opposed to keeping an eye on it regularly. Maybe that's just me speculating.
Right.
But I think because of some of these conditions you've mentioned, there's probably a chance that there are more women in those groups going through the menopause a little earlier.
Yeah.
We know menopause happens 2 to 3 years earlier, a normal menopause in Black women. And that's from studies done in America. But women don't come forward to say, my periods have stopped. Is it a problem? So it might lead to a higher rate of premature ovarian insufficiency, but the menopause experience itself, like I said, it's a biological.
So that's the distinction.
Yes.
Right.
It's a psychological, it's a social mindset phenomenon, and it depends. Everybody is individual. Everybody is different. Everyone is unique.
Yeah.
Women with background of mental health issues throughout their life course may suffer worse with psychological symptoms. Now, because of the allostatic load, so the chronic stress that ethnic minority groups face on a daily basis, which we often just take it as part of a normal day, perhaps that's contributing in some way to, a lifelong history of trauma. It's all these things that we allude to it, we think it might be, but we're not sure.
Yeah, and that. So on the flip side, then, not looking specifically at gynecological, but as Black women have a higher risk of cardiovascular disease and things like preeclampsia and breast cancer, is that a contributing factor? I remember having a conversation with puppies, the study being done at Adam Brooks Hospital in Cambridge, and I never made the connection between certain conditions within pregnancy and cardiovascular issues and things like TIAs and strokes, and how that could be almost warning signs of what may happen within menopause. Do you think there's a distinct link there? And if there is, would HRT be considered safe if there's an increased risk? Sorry, I've got to stop doubling up on these questions, but things keep popping in my head.
No, it's great. It's fantastic. So yeah, you're absolutely right. Black people have a higher risk for heart problems, diabetes, hypertension, stroke, and we tend not to present early, or we don't seek help in time, or perhaps aren't consistent or compliant potentially with medication. The issue of menopause, so we'll take the question of, is HRT safe? That's really important, because a lot of people, and I'm generalizing now, particularly Black women, are scared of taking HRT because they believe it's not safe. Now, HRT is medication, same as paracetamol. I say to people, same as ibuprofen, which a lot of people pop on a daily basis. There will be side effects, there will be risks, but it is about speaking to somebody who's knowledgeable about it, who will prescribe you something that's relatively safe for you, despite the other conditions. Because we see women all the time with other conditions, and we have to then start to think, what is right, what is appropriate, what is effective, what can we do? And it's back to, so the short answer is yes, HRT is safe, but it's obviously, there needs to be an assessment of your health in the first instance to ensure that you are getting the right type of HRT. So that's one thing. The second thing I keep on saying is that it's about looking at the human being as a whole. So it's not just about medication. If it were, and HRT has loads of benefits. It treats symptoms. It helps to protect the heart. So this issue of heart disease and being more at risk for heart disease, HRT, if started at the right time, can be protective of the heart. HRT is protective of the bones. So there's lots of benefits, which we don't often talk about. We only talk about the risks. But again, it's about finding the right HRT for the right woman. So, it's not one size fits all at all. So they can have HRT. They shouldn't be scared about trying HRT. They shouldn't be scared about asking or saying, I don't understand what should I do about this, that, how do I use this, what should I do? It's all those things. It's getting the right information and making an informed choice. But apart from that, it's to do with lifestyle. It's not just medicine.
Yeah.
It's to do with weight. It's to do with blood pressure. How can we help ourselves? How exercise, diet? How can we protect our mental well-being? What do we do for ourselves as women? Rather than continuing on that treadmill, because that's what our mothers did and that's what our grandmothers did
Yeah.
as well, because we're just perpetuating the cycle rather than looking after ourselves. So it's lifestyle, it's mental well-being, it's medication. There's hormone medication, there's non-hormone medication. And even if you're going to use herbal treatments, because some herbal treatments, some people find them beneficial, it's about making sure you're not just wasting your money, but you go to somebody who's knowledgeable. And people say, oh, what should I use? What should I take? I'm not a medical herbalist, so I can't offer that advice. But
Okay.
there's people out there that
Yeah.
sometimes suggest this or that or the other. And it's even if you take those things, make sure that they're not interacting with any other medicine.
Yeah.
So it's the whole picture.
And I think that's a really key point of knowing which professionals and experts to turn to for which information is appropriate for you, your lifestyle, and your beliefs. As you just said, your area is not with medical herbalism. However, if you have a multidisciplinary team that are looking at you as a whole person holistically, and they're able to work together and contribute so that if you are taking a form of HRT and using specific herbs, are they working together? Are you taking St. John's wort and black cohosh, and is that interacting with your estrogen gel? And all of these things are really, really important. So Ade has asked the question, how can we support better information and data? Who is trailblazing in this area when we're looking to ask or find areas where we can go to trusted sources? Who is that person? Is there that person? Are you that person?
There are research studies undergoing. There's I'm not doing any research at the moment, but there are studies that people are doing, and they do pop up from time to time. And then, of course, what often you hear the researchers say is that they weren't able to get the engagement of the Black community, which I disagree with, but that's a completely different story. Is if you don't access people where they are, you will, and you wait for them to come to you, you won't get them to engage in your research project. So who's doing research? I know there's Prof. Joyce Harper in London was undertaking some research. I don't know if it's still ongoing, but there is, perhaps because I'm interested in this space. It pops up on, how social media recognizes what you like looking for and sends you the algorithm.
Listening.
Yeah. So it does pop up from time to time, but I'd encourage anybody who's interested to please, tell their friends, because that's the only way we'll find research that is specifically targeted at Black women, our social beliefs, our cultural beliefs, our mindsets, and Black women is a whole host of different women as well. So underneath that umbrella, specifically, what are the beliefs, what's the culture, how would they like to access care, what kind of care would they like to receive? It's all those questions. Practitioners like myself, we're doing it based on experience and knowledge and, lived experience. It's all those things, but we need evidence, obviously.
I think a good person that I've been following is Karen Arthur. She runs the Joy Retreat and Menopause Whilst Black on Instagram.
There's
another one.
Karanatha, there's Black Women in Menopause,
Yeah.
there's about 3 or 4 others. But, there's people who talk about early menopause.
Mm.
But there are a lot of people doing lots of work in this space. But again, it's about reaching people and people being aware of it as well.
Yeah. Yeah. So many women feel disbelieved about being in tongue twister there, sorry, about being in perimenopause. What is the best way for us to explain our symptoms to GPs?
That's a really good question, especially when you feel under pressure when you walk into a room. I say to people they need to prepare before they go to see the healthcare professional. It's not just about healthcare professionals, it's about how do you talk to your family as well? How do you champion it within your community? But with healthcare professionals, I always say they're human beings as well. Now I know that they're tarred with this brush of they don't listen, etc. But there is usually one who's good and who's nice and who's empathetic and who might listen. So find out who's interested in menopause, I would say, who has a bit of knowledge, who is understanding, and who will listen, but also, if possible, because I don't like to put the onus on women, but if possible, clarify what your expectations are. I usually say keep a diary of what's going on. If you are suffering with symptoms, keep a diary, even if it's for a month or two. See if there's a trend. What are these symptoms? When do they happen? Is it flushing and sweating? And then sometimes you might find that actually it's after you've had a heavy meal of rice or pasta at tea time, at dinner time, that people sweat at night because there's a link. So there might be interventions that one can make already before you even go to see the doctor or to see the nurse. But keep a diary. What symptoms are you experiencing that you think I'm not quite right? And sometimes it's difficult to articulate as well. But if you can say it's I'm sweating or I'm going to pass urine a bit more frequently or I feel odd. So in Nigeria, where I come from, they describe something like pressure in the head. Now, they don't talk about it in this community, but you'll find lots of Nigerian women saying they have a pressure in their head. Write it down. I have a pressure in my head. Often it's the constellation of symptoms together. It's not just one symptom that makes a woman perimenopausal. Is it the joint ache? Now, we don't know what we don't know as women. So even if it's 2 or 3 symptoms that you think this isn't right, I'm tired all the time, I'm becoming forgetful, write that down so that you don't forget, you don't get confused when you go to see the healthcare professional. So you prepare for it, you know what you want to say to them. You clarify, if possible, what your expectations are, because often that's the first thing that they they ask you when you get in there. What are the expectations? And if the expectation is you want to know whether you're perimenopausal, then say that. It's not about going for the medication. What is it that you're expecting from, and I've had women who say, I just want to feel better. And then we can
I was going to
unpick
say the
that.
same thing. Just normalcy.
Yeah, I just want to feel more like myself. And then they can talk to you about what the different options are. And if you're not satisfied, again, with a consultation, please ask to see someone else. We have to speak up for ourselves, because I've seen loads of women where they got an answer and they accepted it, and that was it. They went away and nothing else happened.
They weren't necessarily happy with it.
Yeah.
The fuck happened with the timing?
So there are many of us that have probably spent a lot of our adult life advocating for ourselves when it comes to our gynecological needs, and trying to stay on top of new statistics and be fully informed. And unfortunately, especially when we're talking about the Black and Asian community, it's often that the burden of responsibility for education falls on ourselves. We have to be really proactive in that area, constantly working through each stage and each battle that we're literally fighting in life. when should we start accessing this information? Because I don't know about others, but it's kind of daunting now, because especially with the work that I do, my headspace is very much around when you're in your perinatal phase, when you're in the phase of motherhood and reproduction and things like that. So thinking about it now, I have no choice because I'm forced into it. But when should we really be having these conversations? Often they're left to when we're in perimenopause and things don't feel right. But it doesn't feel quite appropriate that we leave it until that point. Should it be at puberty? What's your suggestion?
I use the analogy of when one was pregnant, everybody had an opinion, everybody spoke to you about it, but nobody spoke to you about menopause or perimenopause. Now, if you flip it around, if a woman's experience of the menopause isn't brilliant, it's going to impact her, it's going to impact her family, it's going to impact her community, it's going to impact her work. Where should people get information from? And there are studies to show that the better prepared a woman is for the menopause, the better experience she will have. So it's not about scaremongering. It's about educating people that will be impacted by the menopause, which is everybody at all ages, that this is a life stage that if they live long enough, they will experience and go through. So in schools, it needs to be part of the curriculum. At work, male and female allies for menopause.
Yes.
At home, people need to be, because that's the only way to make the conversation normal.
Yeah, removing the stigma.
It's about telling everybody about it and saying, and it doesn't need to be in detail, because a 15-year-old girl is going to think, what's my,
Doesn't apply to me.
It doesn't apply to me. I'm not interested. But she might remember, or she might think, oh, my mum might be, is that what's happening with mum? Or auntie, this had something. So we never know where the information may be useful. But it's about making it more, normalizing it within society and within our communities in particular, and not something to be laughed at or to be judged about or to be joked about, to be respectful about it, to not have negative opinions about it, because it will happen to all of us, not to scaremonger people, but to just prepare people. And like I keep on saying, it's not about medicines, it's about lifestyle, it's about mindset, it's about energy, it's about everything. It's about the whole person.
Yeah, it just seems so complex.
It is. It's but we can relatively make it a little bit more simple, I think. I mean, we teach girls and boys about puberty. What's going to happen at the other end?
Yeah. So we just had another question. Bear with me a second. Just to let you all know, the recording will be made available for you all after the session. A message from Kiran. Please correct me if I've pronounced your name incorrectly. They would like to ask, has neurodiversity and being considered a stereotypical angry Black woman when it's anxiety related to ADHD or autism and undiagnosed, then coupled with hormones, been talked about yet? And I think we touched on it a little bit, but yeah, the whole trope of us being angry Black women when it's just the manifestation of anxiety or undiagnosed neurodivergency, and how that then, when we're going through all of these various mental health challenges because of the fluctuation in hormones around menopause, is that being studied? Is it being taken into consideration with diagnosis and when they're looking at treatment plans? Is that something that is being accessible in the care and the responses by healthcare practitioners. You're shaking your head.
Sorry.
You've got experience.
My name's Kieran, like the Irish boy's name, and I'm gutted because the session said that this was starting now, so I've missed out on everything because the timing's being incorrect. I am neurodiverse. I'm going to be a neurodiverse coach. I work in sexual and reproductive health as a nurse, and I can tell you right now it's not covered. 75% of people in jail are undiagnosed neurodiverse. What's the highest population content that are in our jails? It's one of the things that generally black population and Asian population do not discuss, because it is linked with our mental health and is also linked with women. So a lot of the times it's kept secret. And there's a lot of shame linked in with people with neurodiversity and autism and ADHD. So, you know, for me, I am classed as that stereotypical angry black woman, purely and simply because it's actually my anxiety. When I'm anxious, I get angry. And that's how I have my meltdowns. So the amount of patients that I've seen that come in that have been really anxious, really angry, and then have actually calmed down when I've started speaking with them, I can so see how that stereotypical comes in. And then, like I say, you add in the hormones, and this is when most women find out late diagnosis regarding their neurodiversity, actual diagnosis. So then couple that obviously with being sort of multiracial, disabled and everything else, it's a nightmare.
Yeah. And I think that's what we were talking about earlier, about the intersection and understanding that as Black women, we are nuanced. It's not just we are Black women. We could be Black and disabled, Black and neurodiverse. We could be Black and have different communication needs. We could be Black and have limited access to resources and information and socioeconomic barriers and things like that. How can we communicate that the support requirements when we are seeking help for perimenopause?
So back to just to address Kieran's the point that she made about ADHD and menopause, and we see a lot of women with ADHD and in the menopause clinic where they've had difficulties their whole lives, unfortunately, and they then sometimes get a late diagnosis of ADHD or autism, or they never get one at all. But they recognize traits. And I often liken it to they've compensated on top of the other intersectionality of being Black or being whatever other marginalized characteristic, compensated their whole life. And then that's just the last trigger that causes them to decompensate. And it's quite sad, actually, because a lot of this has gone on for lots and lots and lots of years, gradually getting worse. And it's about finding that person who will see beyond that angry facade and understand that there is perhaps vulnerability behind it and other things that might be going on, because it affects the way that they take their medicines as well. If they're going to use that, the sometimes impulsive behaviors where it hasn't worked after a week, so they'll stop. And unless you support people and understand what they're going through, and I agree, it does, there are not many people who may have that understanding out there. It gets very difficult. So it's about, again, seeing human beings as a whole. They're not just, when they come in, they don't write menopause on the paper. And then if it were like that, there'll be an algorithm and they can collect the medication at the door. But it's a bit more than that. And that's why I say, well, at least people will come to speak to me, because it's about that. There is more to it than just here's some medication. And I know services are stretched and there's all sorts of issues. But all I can say, and I think your question, Leah, was about perimenopause. how should we prepare? I can't remember. What did you ask?
How can we, when we are nuanced individuals, how can we prepare so that our communication needs are met? How can
Right.
Are they making allowances?
And that's why I wanted to go back to ADHD, because until you have an understanding of how your brain works, it's going to be really difficult to get somebody to because it might be as simple as saying, I need more time, or I need to be in a quiet environment, or I need somebody with an understanding of this, or if I'm a bit short because somebody was late for my appointment, somebody will understand. It's understanding, trying as much as possible. If we can understand ourselves, then we can potentially. But again, it's back to the support, and it's back to the life experience. It's all those things. And that's why it gets difficult and it gets challenging, because it's really challenging to navigate the healthcare system. I don't lie. It's slightly difficult at the moment. And it's not due to the healthcare professionals, because everybody's trying their best. It's resource as well. So we need to look after ourselves. We need to find safe spaces. We need to try and understand what might be happening, what works for me, what doesn't work for me. We need to write it down.
Yeah. Thank you, Tonye. I'm conscious that we have taken enough of time. I do want to just apologise, because there had been some issues where Eventbrite was giving out various times, and we were updating these, but it just seemed to, I don't know if it was with the clock changes in the US, it kept changing back. As I said before, this recording will be made available, and you can reach out to WRA. We continually try to work with the communities that we are trying to serve when it comes to sexual and reproductive health, and we would be happy to have further conversations and help with signposting. Thank you again, Dr. Tonye Wokoma, for all of the information you've shared tonight. It's been such a great conversation, and we're doing this week as part of Big Give. We are currently fundraising as part of the Women and Girls fundraiser over the next week from the 10th to 17th. So any and all donations would be much appreciated, so we can continue work in this space. Thank you. Julie's just popped the link into the chat, sorry. And yes, please do keep in touch. Follow us on social media. We are very active over the next few days, but we are more available for further conversations. Let us know if there is anything else that you'd like us to address, any other topics that you'd like to have engaging conversations, any resources that you feel could be helpful that you'd like us to consider developing in the future. But most of all, this is a very heavy time. And although we weren't focused specifically on mental health, it can be a very emotive topic, especially if it's something you're experiencing yourself in this time. And so please do take care of yourself. Thank you very much for your engagement, and have a wonderful evening. Dr. Wokoma, if there's anything you'd like to add?
No, be kind to yourselves. Have a good evening, everybody.
Thank you.
Thank you. And yeah, Leah, I'll definitely be in touch. Thank you.
Thank you. Julie's just popped my email in there as well.
Perfect. Take care.
Thank you.
Bye.
Bye-bye.